Good afternoon, everyone. Thank you for joining us for our first of two Lunch and Learns this month, the month of November. I would be remiss if I didn't give a shout out to the Astros. Some of you may be recovering from late nights of partying, I don't know. But thank you for joining us. We contacted the Department of State Health Services and we asked them, who would you recommend come and help us learn more about how to serve communities of color, in particular Black communities, better, where we are and what the situation is across Texas. And they recommended strongly Chris Allen. And so, Chris, I'm very happy to have you here. Chris has a master's of business administration. He worked with the CDC for 6 years doing managing prevention and care programs with minority populations. And he's been here in Austin, Texas for the past 2 years. So thanks for joining us today.
Thank you. Can you all hear me okay? Okay. So, again, I'm here to talk about HIV in the Black communities and some programmatic efforts that are going on across the state right now to try and address the inequities that exist, specifically for Black gay and bisexual men and Black women across the state. Now, there's disparities that are affecting other communities also, and I'll talk a little bit about some of the other priority communities, but I'm really going to focus in on some of the Black communities across the state and what we're doing to try and address those disparities. So again, my name is Christopher Allen. I have to correct that I didn't work for the CDC for 6 years. I was managing CDC-funded projects for 6 years. So I was actually working in Milwaukee, Wisconsin for a community-based organization that was directly funded by the CDC to implement projects for African-American gay and bisexual men in the city of Milwaukee. And so I managed those projects for 6 years before coming to Austin, Texas. And I'm now with the University of Texas at Austin, contracted with the State Health Department as their health equity coordinator. So I'm going to go over some data with you all. This might be data that you already know or have seen before. So I'm not going to spend too much time on the data, but I think it's important to set the stage of where we are here in Texas and what's going on in relation to HIV and our priority communities. And so when we look at HIV diagnosis and people who are living with HIV, and then also HIV-related deaths in Texas since 1980. We can, of course, see the huge spike in the mid to late 80s of new diagnosis, the huge spike of HIV-related deaths of people living with HIV in the late to early 90s. And then as prevention efforts and biomedical advances made way, you can see that started to slow down. So deaths of people are living a lot longer with HIV, and new infections kind of dropped and then spiked and now are kind of stable again. But you'll notice that the people who are living with HIV is on a steady incline, and that's because people are living a lot longer with HIV, and new HIV infections have kind of reached a plateau. So there's still more people who are being diagnosed with HIV every day and less people dying. So we're having more and more people who are living with HIV. And so in the state of Texas, we have 86,669 people who are living with HIV alone, and that's a lot of people. Especially when we compare ourselves to other states, we'll often go to national meetings and talk about, some strategies to addressing HIV in our states. And one of the things that's hard for Texas to relate to with other states is that we have a large number of people who are living with HIV, and we have multiple large metropolitan areas where other states, like New York, has that one very large metropolitan area and then a lot of rural areas. And then California has a very different political climate and very different programs that are addressing HIV than what's possible here in Texas. And so it's hard to try and compare Texas and the HIV epidemic to other states. And then outside of those states, there's very few states that have the numbers that we have here in Texas. So Last year, in 2016, there were 4,493 new HIV diagnoses, and men make up the majority of people who are living with HIV and the majority of all new HIV diagnoses. So if you'll see that small graph down there, about 80%, give or take, of people living with HIV and new diagnosis are among men. And we'll break that down a little bit further as we continue to go further in this presentation. So, Texas and new HIV diagnosis rates by year of diagnosis from 2007 to 2016. So one of the things that is actually great news for us is that the rates of HIV have been decreasing in Texas. Slowly but surely, they've been on a small decline. And so even though the numbers themselves, the number of diagnoses has increased. If we're looking at rates per 100,000, the rates are actually going down. So we're proud of that, and we're looking at why that might be and what we can continue to do to have a steeper decline in those rates. So HIV diagnosis rates by sex and year of diagnosis. And so this is where you'll see that one of the reasons that HIV rates is declining is that we're noticing a large, not a large decline, but we're noticing a steady decline in HIV rates among women. And that's a great thing. So efforts that are addressing women in HIV, and specifically Black women in HIV, they're working. And we need to continue doing that, and we need to figure out what's working with those programs and efforts to see how we can continue to improve those efforts and continue to get this decline. However, when we're looking at rates for men, when it comes to HIV, it's steady. They've been, it's gone up and down just a little bit, but for the most part, it's just been statistically insignificant and a steady diagnosis across the board every year. So HIV rates by race and year of diagnosis. And so again, some more good information, or some good news when we're looking at HIV rates within by race and year. We'll notice that for every group here, they're either staying steady or declining, and that's a great thing. So again, we're noticing that there isn't a huge increase in HIV rates specific to race, but and most efforts are noticing that in general, among all races, HIV rates are either staying steady or declining. But then when we break that out, I don't know what my next slide is. No, we won't get there yet, but one of my next slides will show where HIV rates are actually increasing. And so we'll talk a little bit about that, because this can be somewhat misleading when we're seeing, especially the Black community, from 2007 to 2016, where there's been a steady decrease in HIV rates. But when we're looking at segments within that community, then you'll notice that there's some HIV rates that are actually increasing, and even with the Latino community. And again, I won't speak a lot about the Latino community today, because I'm focusing specifically on Black community, but Latino, gay, and bisexual men are one demographic that is noticing a increase in rates, while most others are either staying steady or declining. But HIV diagnosis rates by age at diagnosis in Texas, and so you'll notice here that most HIV diagnosis is between 20 to 40, and you'll see there's a huge kind of spike within rates for 25 to 29-year-olds. And so when we're looking at current programming to address HIV prevention and HIV care efforts, we're trying to see what is it that's putting our younger communities at a higher risk of HIV. What's causing these increased rates among our younger community? And there's a number of reasons that have come out that address this and that speak to it, but that's one of the issues that we're trying to target when we're looking at new diagnosis across the board for different communities. And so this is where we start to see some not so great news. So new HIV diagnosis by mode of transmission from 2007 to 2016. So like I said, the most all mode of transmission areas are seeing a decrease or staying steady, but gay and bisexual men, or in this case MSM, we're still noticing an increase in HIV rates among this community. And so this is something that's concerning. Gay and bisexual men have always been carried the brunt of the HIV epidemic. And while, in the past HIV rates have gone down within this community, we're seeing again an increase in HIV, and we're trying to figure out exactly what's causing that. And when we're breaking that out by race and ethnicity, I have to apologize because I didn't put these slides together. I just wanted to, I'm using a slide deck that was already created, so if I go off a little bit, I apologize. Yeah, so when we're looking at communities within race and ethnicity among MSM, we see that the reason that there's a huge increase in HIV for the MSM community is primarily with the communities of color. So Black and Latino gay and bisexual men are carrying the brunt of this epidemic. And as I mentioned before, Latino MSM are seeing increased rates of HIV, while between 2014 and now, Black gay and bisexual men have the rates have kind of plateaued a little bit, but before 2014, there was a huge spike in new HIV infections for this community as well. So HIV diagnosis by mode of transmission and sex. And so when we're looking at diagnosis and by mode of transmission for women and men, we notice that the burden of HIV for women is heterosexual women, so women who are sleeping with men. And we're seeing that for men, the burden of the HIV epidemic are MSM, so men who sleep with men. And one of the things that's a little misleading in this category of, or in this way of categorizing people by sexual behavior is that it doesn't take into consideration what sexual identity is. And so when we're talking about trans women, people who were born with a male marker on their birth certificate and transitioned to the female sex, they're categorized as MSM. And so it's hard to, they are a smaller percent of the population, and so it doesn't necessarily change the information too much, but it's a little misleading when we're trying to determine what kind of programs to create to address this HIV epidemic when we're not creating programs that are specifically addressing trans women's needs when trans women are not MSM and have different behaviors, have different social determinants of health that are affecting their risk behavior and their overall risk in general. And so it's one important thing to take note is that when we're talking about mode of transmission and we're looking at MSM, we have to also think about what's included or lumped into that one specific mode of transmission. One thing that I want to point out here that I always point out in my presentations is that a common misunderstanding for risk for heterosexual women is that MSM are putting heterosexual women at risk for HIV. And that's not the case. The research is showing that gay and bisexual men who sleep with both women and men are actually more likely to take preventative measures to protect the women that they're sleeping with. And that one of the reasons that heterosexual women are at an increased rate or increased risk of HIV is because of concurrent sexual partners and a limited pool of sexual partners. 1 out of every 3 African American men are going to be incarcerated in their life if current rates persist. And so there's a small pool or a small population that specifically Black women have when it comes to sexual partners. And then concurrent relationships. So that increases the risk for Black women. And when we're looking at, I think it breaks it out by race. No, I think there's another slide that I'll get out by race, but if there's not, Black women carry the brunt of the epidemic among women in HIV. So this shows HIV prevalence rate by race in 2016. And so again, if you're just looking at the numbers, it can be a little misleading when we're seeing that 22,000 white individuals were obtained HIV, 27,000 Hispanic, 32,000 Black. But when we're actually thinking about the fact that the Black community is only between 12 and 13% of the overall population, and you look at the rates per 100,000, you'll see that there's a huge disparity here when it comes to HIV rates, and that is something that needs to be addressed and looked into to see why is there this huge disparity when it comes to the Black community and HIV infections. So people living with HIV by mode of transmission. So this slide just shows how many people are currently living with HIV, and you'll see that 60% of people who are living with HIV are MSM. Another 24% are heterosexual. 10% are intravenous drug users, and then 5% are MSM / intravenous drug users. And so those are people who identified both of those risk behaviors on their intake forms. And so it's hard to determine whether it was the IDU activities that expose them to HIV or MSM activities that expose them to HIV. So it's all one category for that. So Texas priority populations. So the Texas State HIV Plan identified 5 priority populations, and these are populations that are disproportionately affected by HIV and have health inequities when it comes to HIV, and they experience different social determinants of health that put them at a greater risk of HIV. And they're not listed in any specific priority, so one is not does not have a higher priority over other. They're all priority populations that we want to make sure that we're addressing and finding health equity within. And so that's Black, gay, I always say gay and bisexual men because I personally like to focus on my identity and not my own sexual behavior. I am a Black gay man, and so it's my own preference that I say that, but scientific CDC reporting and stuff like that always use terms MSM. So I might use that interchangeably, but bear with me. So Black gay and bisexual men, Latino gay and bisexual men, white gay and bisexual men, Black women, and then transgender individuals. And so again, like I said, a lot of the data, a lot of the prevention data specifically, data of people who are not currently in care include transgender individuals lumped in with MSM. And so we have very little data when it comes to transgender individuals, but there's a lot of research out there that shows that transgender individuals, specifically transgender women, are at a much higher risk of HIV than any other community of individuals that are there. And so there's a recent CDC announcement, I believe it was actually in 2015, that said one out of every 4 Latino gay and bisexual men will become positive in their lifetime. Estimated 1 out of every 2 Black gay and bisexual men will be infected with HIV in their lifetime if current rates persist. And the rates that some of the research that has been done on transgender individuals show that specifically Black trans women have anywhere from 50% to 75% risk of becoming infected with HIV sometime in their lifetime. And so the research isn't, there's not a lot of great research out there. There's a lot of research that's currently being done, but the research isn't really consistent because of geographical areas that the research is being done in. And so research in San Francisco is of course going to be completely different than research in New York, and so on. And so there's differences in some of the outcomes that are coming from this research, but we're comforted by the fact that there's more research that's being done so that we can get more information when it comes to transgender individuals. So the 2016 Continuum of Care has a goal of 85% of people who are living with HIV be retained in HIV care and treatment. And of those people who are retained in HIV care and treatment, 80% of those people will become virally suppressed. Now, the results of that is where we start to see the gaps in outcomes. And so I'm going to actually start with this lower section right here, communities with the fewest opportunities to achieve retention. So these are the communities who are not being retained in care at that 85% rate. So people who are under the age of 45, people who inject drugs, Black people who are living with HIV, and specifically Black gay and bisexual men. And so they are not being retained in care at the 85% rate that we're hoping for. And so that's why we're looking to see why younger communities and people who are in drugs and the Black communities are not being retained in care at rates equal to their counterparts. And so when we're talking about, yeah.
Does that mean that they're not fine with their care, or
So that means once they're diagnosed, they're either not following up and going into care, or they're falling out of care, not following through with their appointments. And so there's a couple of social determinants of health that are affecting this, and some of it is income, housing instability. There's a number of factors that contribute to the when we talk about specific communities. And so especially when we're talking about some of the younger communities, people under 45, some of it is because they rely on other people for housing, or rely on other people for financial support. And so there's stigma there where they're hiding their diagnosis and fear of disclosure. And so there's a number of factors that contribute to that that all need to be addressed in order to find a holistic approach to retaining people in care. So of the people who are retained in care, the people who are not meeting that 80% viral suppression goal are Black people who are living with HIV, people under the age of 35, and then people who inject drugs. And so the group of individuals that actually have the worst viral suppression outcomes are Black women. And so while Black women are actually retained in care at higher rates than, say, Black gay and bisexual men, they're not achieving viral suppression at the same rates. And so there's a number of factors that can contribute to that. It could be medication adherence. It could be stress-related effects on their immune system, and so, but they're not achieving viral suppression at the same rates as others who are retained in care at lower rates than they are. So when we're looking at the parity bars, I apologize, I'm not sure why. So these last bars over here should be the same color as these bars. So it goes in the order of, so for this first chart, these are white individuals, Black individuals, and Hispanic. And so this is, the first bar is white, Black for the second bar, and Hispanic for that third bar. And then same over here. So it's white MSM, Black MSM for the second bar, Hispanic MSM for that third bar, and then Black women for this fourth and final bar. And so when we're looking at race and ethnicity for parity charts, we're seeing that white individuals are being connected to their first lab visit, their first visit with a provider at higher rates than all other communities. And then even across the board, just white communities have better outcomes and when it comes to being retained in care, being virally suppressed, and achieving suppressed out of being retained in care. So when we look at the Black community, oops, wrong button. When we're looking at the Black community, when it comes to suppressed out of retained, so retained in care, they have a little lower rate of being retained in care, especially when compared to Hispanic, but much lower when compared to their white counterparts. But then even viral suppression, you see a much larger dip there for the Black community. And then like I mentioned over here, when we're looking at our priority groups, remembering that Black women is this last bar over here, for viral suppression, you see Black women are at a lower rate for everyone except Black MSM, but then suppressed out of retained. So for the people who are actually retained in care, their viral suppression rates are the lowest out of all of the priority groups. And so that's something that's a concern that we're looking into and constantly trying to evaluate how we can improve those outcomes. And so I wanted to share with you some current research specific to Black MSM and Black women and kind of talk a little bit about this. And I apologize for the typos. I added these slides kind of last minute. So this should say Black MSM have an increased chance of being exposed to HIV because of the larger number of MSM living with HIV. This higher prevalence leads to higher risk, even with similar frequency of risk behavior as other populations. So what that is saying is it's addressing another misconception that's often heard within communities is that Black MSM have a higher risk of HIV because there's more risk behavior. That's not true. Sexual behavior is actually equal across the board, and some research actually says that Black MSM have less risk behavior than their other ethnic counterparts. And so when we're looking at why there's actually a higher risk for Black MSM, it's because there's a higher prevalence of HIV within the community. And so what that means is the simplest way to explain that is I always use kind of if you picture a pool, and you throw 10 rubber duckies into that pool, and you tell people to jump into that pool. The chances of 10 people jumping into that pool hitting those 10 rubber duckies is somewhat slim. But if you have that same size pool and you throw 1,000 rubber duckies into that pool, and you have those same 10 individual, and you tell them to jump into that pool, their chances of hitting one of those rubber duckies is increased. And so that's how we can think about prevalence within a community. And so it's not necessarily that there's more risk behavior that's being done. It's not that they're using condoms less or not taking preventative measures, but it's because there's already a higher prevalence within the community that puts them at a higher risk of HIV. And research shows that most individuals have sex with their same ethnicity. And so when we're looking at Black gay and bisexual men, most Black gay and bisexual men have sex with other Black gay and bisexual men. And if they are having sex with other ethnicities outside of that group, like say a white gay or bisexual man who's having sex with Black gay or bisexual men, their risk is actually equal to that of people who are in the Black community because they're having sex with other Black MSM. And so it doesn't change their risk by trying to find a sexual partner outside of their race or ethnicity, because that sexual partner outside of their race or ethnicity is jumping into that pool with 1,000 rubber duckies. So that second point, Black MSM are more likely to report taking preventative measures, more likely to report receiving an HIV test in the past year, and more likely to have a history of repeat testing. However, they are still more likely than any other ethnicity group to test positive for HIV. And so, like I said again, this points to prevalency being the issue here and not necessarily preventative behavior. And then one of the things that we have been trying to make sure that we communicate with our community-based organizations across the state, and community-based organizations are communicating to their communities, is that having an HIV test is not necessarily prevention. So sometimes individuals will think that, I get tested once every 3 months, or I get tested once every 6 months. I'm okay. That's all I have to do. But that is not prevention. Getting tested is just knowing your status. And so you actually have to take efforts to prevent HIV, whether that's using a condom, whether it's being on PrEP, whether that's serosorting, whether that's choosing your position based off of which sexual position is at a lower risk of contracting HIV if you don't know the person's status and stuff like that. So actually using safer sex measures to prevent HIV. And so it's a way of trying to kind of teach people about preventative behavior that isn't stigmatizing their behavior, but letting them know what risk exists. Because one of the reasons people are at risk is because sometimes they underestimate what their risk is. They don't realize that there's a high risk for them to contract HIV. More research for Black MSM. So Black MSM are more likely to be unaware of their HIV positive status. Individuals who are unaware of their status are more likely to engage in behaviors that may transmit HIV to HIV negative partners. So this is comes from a source, because all of the sources are on the last slides of this presentation, so you can kind of check that out. But it's important that once people do get tested for HIV and they know that they're HIV positive, they're less likely to expose sexual partners to HIV. And so it's important that we make sure that we're communicating the importance of getting tested and knowing your status and then linking them to HIV care and treatment, because that decreases the risk, the community viral load when it comes to the virus within the community. So the second point, based on 2015 data, Black individuals made up about 13% of the U.S. population, while accounting for an estimated 40% of all people living with HIV and 45% of all persons newly diagnosed. And so again, this is just to point out that health inequity there when it comes to HIV and Black individuals. And I think this is the last slide for health inequities for Black MSM, or research on Black MSM. So stigma, homophobia, and discrimination put MSM of all races and ethnicities at risk for multiple physical and mental health problems and affect whether MSM seek and obtain high quality health services. So one of the research, EpiAid research studies that was done by the CDC in Milwaukee that I was a part of in I think 2009 or 2010, looked into seeing why MSM of color, specifically Black MSM, were at a higher risk of HIV in Milwaukee. And they found that there were a number of factors contributing to the high risk of HIV. And it didn't mean that other ethnicities weren't also, that these weren't risk factors for other ethnicities, but they were identified as some of the leading risk factors for Black and Latino MSM. And some of that was lack of community support, fear of disclosure because of HIV stigma and anti-gay discrimination, and then resignation and feelings of hopelessness. And so many of the people that were talked to during that research said that there was a lack of sex education growing up, and they didn't fully understand how HIV was transmitted. And so some of the people who responded to that investigation stated that they thought that just by being a gay person or being a person that sleeps with other men would create HIV, and that there was a given that you would automatically obtain HIV in that way. And so they didn't actually understand how the virus was transmitted. And so, of course, without that sexual health education, they didn't see the need to prevent HIV because they thought that it was the sexual behavior that created HIV and not a virus that was being transmitted. And so also, because of the stigma, the anti-gay discrimination and the stigma around HIV, there was fear of disclosing the HIV status if they knew their HIV status, fear of getting tested if they didn't know their HIV status because they didn't want to know if they were HIV positive because of the stigma associated with being HIV positive. And all of that led to kind of this don't ask, don't tell kind of mentality when it comes to having sex. The people who responded and who were interviewed stated that they would assume if their sexual partner didn't ask to wear a condom, then that their sexual partner was negative, and so there was no risk there. And then the people who were living with HIV said that if their sexual partner didn't ask about a condom, they assumed that person was positive, so why bother? And so there was this kind of lack of communication that led to false or incorrect assumptions among sexual partners, and so that created a risk there. And so when we're talking about resignation and kind of hopelessness, when kind of incorporated or along the lines of that HIV or anti-gay discrimination and HIV stigma, there was a kind of less willingness to maintain their own personal health or to care about their own personal health because there was less value seen in themselves as a gay individual or as a person who was living with HIV. And so that led to, if you're living with HIV, not following through on appointments, not following through on taking medication, and increasing that risk. And then if you weren't living with HIV, there was this kind of, oh, well, does it really matter anyways if I'm protecting myself because I'm a gay man, and all of this stuff in the news about how it's wrong or we shouldn't have equal rights or stuff like that creates this kind of sense of being devalued that leads to more willingness to ignore risk or take accept risk as something that's just a given because of who you are. So while Black MSM are less likely to engage in most risk behaviors than other MSM, i.e. Unprotected anal intercourse, more sex partners, more drug use before sex, or use drugs or alcohol during sex, again, they're less likely to do all of that. Black MSM are more likely to report sex work than other MSM. And again, I'm going to go back to the research that I was a part of in Milwaukee. And one of the reasons that Black gay and bisexual men were more likely to report sex work was because of survival sex. Many of them reported being kicked out of their homes when they came out or when they were forced to come out to their families. There was lack of community support. And so in order to have a roof over their head, they would house hop and exchange sex for having certain needs being met. And then another reason that this number is high for Black MSM is, again, that transgender women are being lumped into that MSM category. And one of the things that we see with transgender women is that one of the things that I want to make sure that I say is that sex work is not synonymous with being a transgender woman. And so just because a person is a transgender woman does not automatically mean that they're going to be in sex work. But we often see that transgender women resort to go to sex work in order to get their needs met because of their desire to be seen as the person that they are. And so they are often discriminated against by employers, by landlords if they present as a woman or if they're not passable as a woman. And so one of the ways that is somewhat acceptable is sex work to achieve money. And so they'll find ways to get their needs met by doing sex work and still being able to find confirmation in who they are by being able to present themselves as who they are as a woman. And so we see that this information is somewhat altered when we're talking about Black MSM because that includes a lot of information about transgender women. So current research on Black women. Black women accounted for 62% of new HIV diagnosis among women, but only 13% of the female population. And then fundamental determinants of HIV risk among Black women in the United States are social inequities involving race, class, and gender, including in inequalities of gender, race, and class. So that intersectionality there where all of those different forms of discrimination can kind of meet and culminate in worse health outcomes, access to the healthcare system, and being socially secure. And so when we're talking about current research specific to PrEP, there was a multi-city study of Black MSM and transgender women that found that 39% of participants were aware of PrEP, but only 4.6% were currently taking PrEP. And so there is a huge gap when it comes to the number of people who are aware of PrEP and the number of people who are taking PrEP. And some of that is, again, potential barriers to PrEP for Black MSM and trans women include perceived cost, concerns of long-term effects, having to take a pill every day. And so some people see this as you're just trying to prepare me for being HIV positive. If I have to take a pill every day, then how does that differ from actually being living with HIV? And so there's kind of that misinformation there about understanding what seasons of risk mean, understanding that taking PrEP is not a lifelong thing. And so there's more education that's needed. Concerns that people might assume the medication is to treat HIV. And so because it's Truvada, and if someone were to kind of type in that information, if they saw the pill bottle lying there, they'll see that Truvada's is a medication that treats people who are living with HIV. And so there's a concern that if someone sees them taking this medication, the stigma that's associated with being HIV positive will then be placed on them as well. And so there's a number of other barriers that have been identified also, but those were a few that just stood out. And for Black women, a lack of interest in PrEP is associated with I want to say that the low education level is not low education as far as institutional education, but education on PrEP. Perception that they're at low risk, so there's lack of awareness of how much risk is actually within the community for Black women. And so there's recommendations to improve use of PrEP for Black women, including integrating PrEP into existing health systems, addressing individual factors that influence adherence, and then address community factors that address adherence, such as HIV stigma. So talking about some of the current efforts that are going on to address gaps in outcomes that within the State Health Department and with the State Health Department's partnership with the University of Texas at Austin, there's focused HIV prevention efforts. And so that includes evidence-based population-specific interventions like group-level interventions and community-level interventions. So there's the interventions that are supported by the Centers for Disease Control and Prevention, like Many Men, Many Voices, Empowerment, and these have all been proven to be effective within certain areas and continue to be effective. But one of the issues with evidence-based interventions is the scalability. And so while it has an impact on small numbers of community members, once they go through certain individuals, the impact, it's hard to scale that impact. And so one of the EBIs that has proven to be somewhat scalable, Empowerment is a community-level intervention that uses a core group of individuals. So in this instance, what we can say Black, gay, and bisexual men who come together, plan out activities, work to increase visibility and education within their communities, host small events, large events, community events, and disseminate that intervention throughout, or disseminate that information throughout their community as a whole. And so that's what we're looking for when we're looking at interventions that can be scalable and have a much larger impact on overall communities. Community-based outreach and testing, so that's just, again, going out, feet on the ground, boots on the ground, getting people tested. Routine testing. So the State Health Department is working really hard to work with medical providers to do routine HIV testing and provide that in as kind of routine health so it becomes normalized. And that can also kind of take away some of the stigma associated with HIV in broader communities. However, again, that has limitations because, as we know, there are certain communities, in this case, the Black community, that sees a medical provider at lower rates than other ethnicities and communities. And so even if we were to routine testing, make HIV testing routine, it would have a limited impact on certain communities because of the how often they go to see a provider. And then community mobilization. So a lot of the work that I do is within communities to mobilize communities to identify what the issues are and find ways that the community sees they can make an impact on those issues. We notice that a lot of the programs that have the largest impact are programs that are created at a grassroots level by communities, for communities, because of the work that they've done. And we see that when the state comes in and says, you're going to do this program with this community, it has a limited impact because it's not necessarily tailored to what that environment needs. And so I partner with the State Health Department to really go out into communities, help communities do a kind of needs assessment and identify what are what do they see as some of the leading factors to the HIV epidemic within their communities, and then start identifying ways that they can address that based on their community's level of readiness. It's important to identify what the community readiness is for addressing issues so that you're not trying to go out there guns blazing and then you're met with a huge resistance by community that's like, no, I don't know what you're talking about. We're not even acknowledging that HIV is a problem. And so if they're not acknowledging HIV as a problem, you have to start with education. And so where do we start and how can we start there? And what resources are already available within communities to do that? Cultural awareness and creating equity trainings, where we've created trainings for the State Health Department in Austin, and we also we're creating trainings that will go out to CBOs across the state that really focus on how can we take a a historical approach to understanding why there are racial inequities when it comes to health outcomes, and really learning from that to adapt our services so that we're looking at things with a historical context. It's important to understand where we were as a country and what has led to certain communities having lower health outcomes than others, and so that we're not placing the blame solely on communities, but we're also understanding that systemic issue that kind of created that. Focus on addressing health equity through capacity building and technical assistance. And so we have the Texas Black Women's Initiative and then the Texas HIV Health Equity Initiative, which I'll talk a little bit more about. The Texas Black Women's Initiative has the mission to promote active, engaged, and empowered communities to address HIV disparity among Black women and other women of color related to HIV prevention and care, and to achieve sustainable systemic change. And so there's 7 regional groups, and like I said when I was talking about these community members across the state coming together, identifying issues, and creating programs to address issues that are within their communities. That's what the Texas Black Women's Initiative is doing. And so there's a group in Houston that is working really hard on certain projects, and groups across the state doing the same thing. And that's also what the Texas HIV Health Equity Initiative is doing for Black and Latino, gay and bisexual men, and transgender individuals across the state. And so there are 6 regional groups across the state that are identifying issues and creating projects to kind of address those issues again also. And so we're working with these communities to kind of build these projects. And then we also have a micro grant project that we will they can apply for funding through that microgrant project to see if they can qualify for funding to help get some financial support from the University of Texas at Austin to keep those projects moving for a one-time year course, and then help them find other ways to sustain those projects after that. But it's one way of trying to really build up those grassroots projects and create momentum within communities. So there's monthly technical assistance and capacity building calls focusing on best practices, sharing lessons learned, and engaging statewide community members on a specific topic. And so the Texas Black Women's Initiative and the Texas HIV Health Equity Initiative all come together during these calls to really communicate and see what are some lessons learned, what are some challenges that they're encountering, and how they can continue to build off of one another. Even though Texas is a large and diverse state, there's some areas where there's something that didn't work here might actually work in another area, or something that's not working here might not be working there, and they learned how to overcome a challenge that others can learn from. So it's important that we're connecting these people across the state with one another, so that they can share that information. And so some of the topics that we discussed during these calls are HIV in rural Texas, and how urban areas can be help take a statewide approach to addressing HIV in rural Texas, addressing the needs of transgender individuals, addressing social determinants of health, and then finding small wins. And so this is one area where because there's limited funding and there's limited resources, and we might look at these statewide rates and become very discouraged. But when we're out there as an individual having one-on-one conversations and doing the work, it's important that we see the impact that we're having in our day-to-day work, and not being discouraged by the statewide numbers. And so talking about what does it mean to actually be successful. I think this is the last slide. So internally within the State Health Department, I've been leading some health equity work where we have conversations, because the State Health Department being based in the HIV STD TB branch being based in Austin is not necessarily diverse themselves. Austin is one of the large cities that's experiencing a shrinkage when it comes to communities of color leaving the city because of increased cost of living, gentrification, and all of those other things that come with a bustling city that's experiencing a tech boom. So it's important that we have these conversations within the State Health Department to understand what their role is as a gatekeeper, where they have power interpreting information, defining reality, counting and measuring information, translating information, controlling the flow of resources, and speaking on behalf of communities, that they include these communities in those decision-making processes. Because a lot of the time, they don't represent the communities that they're speaking on behalf of. And so it's important that while good intentions are there, that they're not having a negative impact on communities unintentionally. And so including communities in their decision-making process. And they do a great job of that with the Texas HIV Syndicate and other projects that they're doing, but it's ongoing conversations on trying to determine how we can have an equitable impact when it comes to addressing HIV across the state. So these are a lot of the references. Any data that any data in this presentation can be found on the Texas Department of State Health Services surveillance reports website, and so there's a link that you can find all of that unless otherwise indicated, and so that's where the rest of the resources comes from. Any questions? No, we're kind of low on time.
Any questions from the offsite?
Yes.
I have a question. Is your PowerPoint going to be available?
Everyone should have gotten an email. If you registered a PIF, you should have gotten an email with a PowerPoint.
Is it already on there? Thank
Yeah.
you.
All right. Well, thank you so much, Chris.
No problem. And if you, thank you. And if you have any questions or comments or want more information, feel free to contact me. I'm more than willing to answer anything. Yeah. So thanks.